Welcome, everyone, to episode 3 of Humanizing Healthcare Session 1. Today's session will be my story. We will be reviewing 18 months in the healthcare system of my own personal experience. And at the end, we will talk about some outcomes and some lessons learned as we went through that system. We will be comparing things throughout to the framework that was mentioned in our introduction, where we talked about the PDACL, Preventative, Diagnostic, Acute, Chronic, and Life framework with the various stages, addressing the why people go to the medical practice. And we've created a theme for this series, and the theme is humanizing and efficiency are not competitors, they're collaborators. So when we look at this, what I want you to think about is how the impact of humanizing and the efficiency component played into my series of visits over an 18-month period. And so as we go forward, please keep in mind that this is not a commentary about my personal health. It's a commentary about the healthcare system. So I want you to keep that in mind. So as we begin, it was in September of 2024. Just prior to that, I had noticed some vision issues. And I decided to go to my retinal surgeon, who I had seen before because, frankly, I'd had a detached retina and a macular hole. So it was sort of a time to go see him. When I got to his office, and they put the chart up to review the eye, the numbers or the letters on the screen, I could only see 2 of the 4. And I turned my head and I could see the 4. So he was concerned, did an angiogram, and discovered very quickly that I'd had a stroke in my left eye. That stroke in my left eye then caused him enough concern. He said, "You're either going to the emergency department or you're going to see a cardiologist." Well, fortunately, my cardiologist was across the street. Went to his office, got on the schedule for later on that afternoon. The cardiologist said, "Doesn't appear to be a cardiology issue. Let's get you to a neurologist," who happened to be a friend of mine. Contacted him, got to see the neurologist the next afternoon. Long story short, the neurologist went through an evaluation and an assessment of what my issues were, ordered a field study, ordered some additional testing, and discovered that I may have a need for a biopsy, referred me to a surgeon who then was able to get me into the ambulatory surgery center to do a biopsy on my temporal artery. And as it turns out, I had what's called a giant cell arteritis, or an inflammation of the arteries in the head, and that was more likely than not the cause of the stroke. So as a way of treating that, I was referred to a rheumatologist, and the rheumatologist said, "Here's what we're going to do. We're going to start you on a very high dose of prednisone, 60 milligrams, and we'll gradually taper that down and hopefully get you off within the 12 to 18 months or potentially 24 months later. We'll also start you on a baby aspirin." So in that 31 days, in September and October of 24, I had 16 different visits in 10 different locations, and I had 10 different physicians involved, 6 that I saw personally, and 4 that did the interpretation on the results of the various studies that I had. So as you think about this, here I was going through in the framework that we talked about, diagnostic and acute stages. And had I not been treated, I may have lost my sight in my left eye. So I think it was very important to have gone through this. So here I am then in October, November, December, in a chronic state with my prednisone, and my prednisone continued to go down a little bit each month. But in January of 2025, because of the fact that it was winter and the heater was on and so on in the house, I got a nosebleed. I couldn't stop it. Called the EMS. They came, said, do this, this, this. It should work. That didn't work. Later on that day, I went to the emergency department. And making, again, a long story short, they couldn't get it to stop, monitored, and said, we need to admit you to the observation unit and get a ENT specialist to come to see you. Well, it happened to be in Houston, a time of snow. And so the ENT specialist didn't come until later on the next day. So it was about 24 hours after I was admitted to the observation unit that the ENT specialist came to see me, said, we need to cauterize your nose. And he went to the emergency department. They didn't have the equipment. The observation unit didn't have the right supplies. So he went to his office, fortunately on campus, and came back with the right supplies, cauterized, and the next day I was discharged. Well, lo and behold, that led to me becoming a victim of aspirational pneumonia. And so here I am again, an acute stage with the nose, in an acute stage with the pneumonia, and having been diagnosed in that capacity with various mechanisms. So all good. Continue then. The pneumonia settled down, and I continue on the chronic stage of dealing with the prednisone. In June of 2025, after working out over a period of several weeks, I just couldn't handle it anymore, in that it was because every time I tried to do a push-up, a burpee, a plank, I was short of breath. I commented on this to the rheumatologist as I went through, and they just didn't feel like it was that big a deal. Eventually, I went to the emergency department again, was referred to a pulmonologist. Pulmonologist said we need to do a bronchoscopy. So they did a bronchoscopy. And what happened with the bronchoscopy was interesting, because they discovered that I had a Mycobacterium simiae infection in my lungs. Now, wait a minute. This is all confusing to me, but okay, fine. So they referred me to an infectious disease physician. And that happened closer to, in August. And I didn't see the infectious disease doctor the first 2 visits to his practice. I saw the physician assistant. They put me on a planned strategy of 3 high-dose antibiotics. Finally, when I went back to the pulmonologist, he said, you haven't seen the infectious disease doctor? And I said, no. So he called the infectious disease doctor and said, you need to see this person. Well, when we saw the infectious disease doctor, he made 2 very interesting comments. Comment number 1 was, these cardiologists and pulmonologists, they dump their patients on me all the time. And the second comment was, I don't think I need to see you anyhow for what you have. Well, that turned us off. And when we went back to the pulmonologist the next time, we said, I'd like to see a different infectious disease doctor. So the pulmonologist said, okay. So we got set up with another infectious disease doctor, went to see him, and he was outside of the system that I was in. He was at another hospital, but he was kind enough to be able to see us. The interesting thing here was that even though all of the other physicians that we had seen were part of an ACO kind of model, and they had access to my medical records, so it was a fairly smooth flow of the interoperability of the information flowing. Well, this second infectious disease doctor was not part of the system. So the pulmonologist had to fax over 70 pages of information to the second infectious disease doctor. When I saw him, he had reviewed all the information, spent about 45 minutes with me, and my wife, because it's always us that go to see the doctors. And he said, well, you don't have Microbacterium simia. You don't fit the symptoms. You don't fit the profile. I don't believe you have it. Stop your antibiotics, and we will then refer you back to the rheumatologist for further treatment and to the pulmonologist for further treatment. So here's the funny side of the story. I'd seen a cardiologist, a neurologist, a general surgeon, an infectious disease doctor, and primary care. Well, I hadn't seen primary care at this point, but my wife kept saying, "We keep seeing all these ologists." That first infectious disease doctor was a quackologist, based on his response and how our feelings were related to him. So the quackologist was out of the picture. The second infectious disease doctor said, since it's not an infectious disease, we won't have to see you any longer. Go back to your pulmonologist and your rheumatologist, and they'll treat you forward from there. So we were off the antibiotics and back on the prednisone scenario. But what was the cause of the lung problem, the shortness of breath that I was feeling? Well, they didn't know, but they felt like it was an autoimmune issue and that the prednisone probably would help. So we were on that. However, then the rheumatologist said, let's try something else. So they just said, let's do another drug. They put me on another drug that was designed to treat the rejection or the autoimmune status of my lung situation. And that actually seemed to work. So at this point, I was on 2 maintenance drugs, which is what, in the definition of chronic care, what you're doing is you're helping to maintain and managing the systematic issues. So I was on the prednisone and the second drug. And as it progressed, everything was going along really well. And in February of 2026, I had a second bronchoscopy. It revealed nothing in terms of the infectious disease. So the second infectious disease doctor was right on, and everything was good. So I'd gone through this period here where I'd seen 19 different physicians. I'd seen in 18 different locations, and I'd had 13 different procedures done. Now, procedure, I make that as a broad definition because a lab draw is not necessarily a procedure, but it was 13 different types of things done to help me in the diagnosis during my acute stage, leading to me becoming in this chronic care situation. But also, as a sidelight, in this 18-month period, I'd seen my primary care physician twice for my annual Medicare visit. I'd seen my urologist twice because I needed to, or I like to be checked on a preventative basis for my prostate situation. And I'd seen my dermatologist once to doing a preventative skin test. So all of a sudden, then I've gone from seeing 19 physicians to 22 physicians in an 18-month period. And fortunately, all of this has gotten me to a position of being stabilized on these 2 maintenance drugs and hopefully continue to move forward. So that's a very brief version of my story, if you will, in terms of what goes on, as what has gone on in the healthcare system. A couple of comments here, though, relate to the kinds of situations that we have, in that the system worked to a degree. The referral process, not sure, because of that exposure to that first infectious disease doctor. So there were some things there, but let me do a little bit more then in terms of commentary and addressing kinds of the issues and the lessons that I learned. And again, the big outcome is I can see. I don't have a loss of vision or a blind left eye. that I could have had I not been able to respond as quickly as I did relative to seeing the cardiologist, the neurologist, and the neurologist managing me through the process to get me to a stable situation. So I think that that's a very important point to make, that that I have that my sight back. In addition to that, the current status of my health is that I will have this autoimmune disease, and they've defined it now as pulmonary fibrosis. And I will have this with me for the rest of my life. So I will be on maintenance drugs for that forever. And that what it's done is it's affected me a little bit in terms of my exercise and my routine. So I no longer can do as much strenuous type of activity that I've done in the past. So I still have the issue when I try to do push-ups and planks and burpees and so on, that I can't do those face down to the floor. I have to modify that. In addition to that, it's a strain to lift heavy weights. So my routine now is to go to the gym 3 days a week for a class. In addition to that, I do some working out, and then I walk every day at least 12,000 steps, because I have a little 7-pound Chihuahua that we love to go for walks. So that works out pretty well. So my health outcome is fairly positive. Is it ideal? No, but it's good. So as we think about this, I had the PDAC as a big set of impacts on my different stages as to why I went to see a physician. We had preventative visits, we have diagnostic visits, we have acute visits, and we have chronic visits. Haven't had any of the L, and the L really is more designed for end-of-life situations. So I'm fortunate not in that situation, because none of this is fatal, none of this is critical. But the interesting thing is, when I was in the rheumatologist office, I saw a brochure for a hospice. Rightly so, they should have that. But it really struck me. I said, wow, I'm so grateful that I don't have any of the L issues that relates to the various stages in the framework that we have defined. So health outcome being positive. So let me do another thing here. As I said, I went through all of these different physician practices, and let me grade them and tell you on a letter grade. As a professor, I like to do the ABCDF situation. So how about the retinal surgeon? How would I grade his office? Well, he's the one that detected and determined that I had the stroke and needed to be seen. My repeated return visits have all been positive. Everything is stable. But I'm only going to give him a B. And the reason I'm only going to give him a B is because he has significant turnover in his office. And I see him about every 3 to 4 months. And virtually every time I see him, there's somebody new. So there's a lot of turnover. I have no idea why, but there is that. The cardiologist, the second doctor that I saw, what am I going to grade him? I'm going to grade him as a C minus. Why? Well, how do they answer the phone? Remember in our episode 2, Dr. Neil Baum said, make sure that you answer the phone with something other than doctor's office. Well, guess what? They answer the phone, doctor's office. In addition to that, the reason that I was able to see him as quickly as I did was the retinal surgeon in September of 24. I saw him on a Tuesday morning, and I saw the cardiologist that afternoon. The reason I was able to do that was because we know from experience that it's difficult to get in to see the cardiologist, and their office is not function very well. So literally walked across the street, was able to get on the schedule. So we were fortunate there. So should they get an A? No, they still get the C, because they don't have the culture in their office is not the greatest as far as the efficiency question and the relationship to the patients that we would have. The neurologist, awesome, B plus. Staff is very friendly, very efficient. Seen him on a number of occasions, and all of that is really good. The surgeon obviously didn't have to see him too often, and his office gets a good B or a B plus in terms of ratings. The rheumatologist, I've seen the rheumatologist, I don't know, feels like 100 times. But it's at least every other week for a long period of time. Now it's on a monthly or a little bit longer basis. How would I rate that office? I would rate that office as a B plus. Staff was friendly. One of the advantages of going to an office frequently is you get to know the staff. They get to know you. Everything seems to be more cordial and so on. So that's a real plus kind of situation there. In this time frame, rheumatology practice itself was part of a larger group. They left that group, joined another group, and they converted to a different EMR. So there were some conversion issues that went through, but they seemed to handle it well from a patient perspective. So all of that was very good. So I think we're pretty decent there. Now the pulmonology office, we're going to give them a C plus. And the reason we'll do that was because actually the staff is very cooperative and cordial. That went well. The efficiency of the visit was pretty positive. They've done pretty well. The bad news is that referral process from the pulmonologist to his friend, who is the infectious disease doctor number 1. When we saw the infectious disease doctor number 2, he said, it's interesting that you were referred to infectious disease doctor number 1 by that pulmonologist, because that pulmonologist refers his family to infectious disease doctor number 2. So that was an interesting thing, and I think is a big point to make in terms of where we want to go. As we move forward then, I think it's important, and I use this grading situation to say, well, why didn't everybody get an A? I mean, because look, my medical situation is fine. I didn't give everybody an A because there were little things that happened. Probably one of the most interesting observations that I could make is that each office, the front desk staff, the medical assistant team, and so on, the check-in, check-out process, the phones, and so on. All of those individuals are task-oriented. I didn't get warm, fuzzy feelings about, well, hey, it's great to see you, and thanks for coming in, and so on. And if you'll recall our definition of humanizing, when we talked about humanizing, we talked about 4 different things. We talked about respect, compassion, listening, and transparency. Well, did I get respect? I suspect I was treated that way. Did I get compassion? Not necessarily. Did I get listening? Sometimes, but active listening is people looking at you, people responding, and so on. I say I got some listening, and then transparency. Really, the interesting thing about transparency was, again, most of the doctors were part of the system. So there was a patient portal. I was able to get the information relative to my health status, the results of my studies, and so on, relatively quickly. That went fairly smoothly, but it really points out the need for a more effective interoperability. I didn't necessarily care for the fact that, in the EMR situation, I was reminded a week in advance. I was reminded 2 days in advance, the next day. And then on the day of the visit, 1 hour before the visit, I got a note that said, "Are you here yet? Have you arrived?" Well, I think there's some redundancy built in, obviously, to affect no-shows and so on. But is that the right way to go? I don't know. So when I think about this, probably the most important thing that I could share was everybody's task oriented. There was very little effort toward humanizing my visits, and I think that that's a very big message to get across. So if I were to summarize everything, my observations, as I said earlier, my outcomes are positive. The collaboration, the relationships that existed in most cases, except for that referral to infectious disease doctor number one, worked pretty well. The scheduling capacity worked. In my case, I was able to get through and didn't have any 6 month delays or anything like that. Well, why is that and what happened? And here's my question, because I know how the system works and have been involved in the system for almost 60 years. It's like I know how to make a B, C, D, and E. Now, a question that has to have been bugging most of you is, where were the prior authorizations? I didn't need any. And the reason I didn't need any prior authorizations was because I'm on traditional Medicare with a supplement. And that supplement is a Plan F supplement, which is no longer available. But that meant I had no copays, no deductibles. Everything was taken care of by Medicare and my supplement. I had no need for prior authorizations, so everything in my case went very smoothly. Wouldn't that be ideal in all cases, that we'd be able to have that? It is what it is, but the bigger question here is, what happens to somebody who doesn't know how to manage the system? What happens to somebody who needs prior authorizations as they went through this? As I said, I went through my 31 days to get from an acute state to a firm diagnosis and a solid treatment plan. That's pretty amazing, basically, when you think about that. So, but what happens to others as we go through this? I don't know. The interoperability question there's still gaps. I was able to, by my cardiologist, by the way, I went to see him this past week. He now has a patient portal. He didn't have a patient portal prior to at least my exposure to him in the last week or so. So here we look at interoperability, patient information, the transparency question, and so on. There still are a lot of gaps in the system that we have that we need to think about and need to look at. Another observation is the AI growth. And when I say that, all of a sudden now I have some ambient reports on my status from my visits. And interestingly enough, my report for my visit could actually be on my computer or on my iPad before I get home. So there is some benefit to that in terms of transparency. But as I mentioned earlier, maybe they ought to curtail a little bit some of the notifications on the visits and so on. So it's not all total user friendly and so on as we'd like to see it. So I think that there's some issues to go along with that. And I think the other key point here, part of the big humanizing efficiency question, is what's happening with the staff relative to compassion, what's happening to the staff relative to communication. I think it's important for us to do the analysis of our practice, internally as well as externally. The external analysis is looking at that interoperability and the referral patterns. The internal scenario is really where we want to focus on, do you train your staff? Does your staff have the right skills to meet the demands, not only of implementation of AI, but of being able to move forward? And how are they related to, and how are they trained to respect, express compassion, and listen, and so on, so that we get more of the humanizing pieces. The AI can do a lot more technical stuff, improve overall functionality, hopefully make the system more efficient from point of view. But what does that do for the staff? It frees up the staff to be able to think about, to be able to work toward, and to relate better to the patients on each patient visit. So in summary, I went through 4 stages of the framework over an 18-month period. I saw 22 different physicians in 18 different locations with 13 different procedures. So I was part of the system. Did the system work? Yes, but there are gaps that are here. I'm not being critical at this point in time. I'm being observational in that as we think about what we can do as administrators, think about what it is in terms of the functionality and the flow of what goes on in your practice and how can you make that more efficient. And do I have the right staff with the right skill set? I need to be aware of that. As clinicians, using the AI for different techniques and so on will be a benefit to you in terms of assisting with the diagnosis and the treatment plans and so on. But also be aware of your referral patterns and how that gets managed and where that goes. And then for the IT people, interoperability. For the rest of the staff, be open. And not only then does the humanizing relate to the patient relationship, it relates to each other. So as we think this through, the system of the interoperability of going back and forth, but also the system of the interoperability in the office, when we think about the handoff from the front desk to the medical assistant to the provider, back to the medical assistant, back to the front desk, how does that handoff work? Is that 5 or 6 silos? Or is that a complete system that functions and flows very smoothly? So the challenge that we would have is for you to think these things through as you move forward. And what we will be doing as we progress in this series of humanizing healthcare is we will be interviewing other physicians, team members, patients, and people who are not part of the healthcare system in terms of how functionality works outside of healthcare. Maybe we can learn from others. So we will be focusing then in the future on what happens with the greater system framework, the framework within the office, and how all of those pieces fit together. So I'm looking forward to getting some feedback. And again, just to remind you, based on what we've talked about today, I want you to think about your practice. If you looked at yourself or your practice in terms of the Olympic medals, have you done well enough to get a medal, or are you non-medal? If you're a bronze, silver, or gold, how could you classify yourself as being a bronze winner, a silver winner, or a gold winner of how you've implemented, how you've reviewed, how you've analyzed, how you've trained, how you've manipulated, changed your flow, how you've integrated AI into your system. And what I'd love to have happen is I would love you to think about this discussion today, grade yourself, give yourself a medal, and then share your thoughts as to why you did or why you haven't achieved that, and send them to me at odahl@owendahlconsulting.com. And the more input we get, we'll be able then to share that knowledge and share that information with the others that are listening to the additional episodes that will follow. So in conclusion, hopefully we've given you information today that makes sense to you, that you will then convert to knowledge and apply that knowledge to your practice and take action. So the IKA acronym, information, knowledge, and action, is hopefully an outcome that each of you will experience. So I want to thank you very much for your time today. And again, if you have any comments, please pass them on to me at odahl@owendahlconsulting.com. And please hit the subscribe button and be able to and plan to subscribe to this channel so that we are able to give you all the information in a timely manner as we proceed with additional episodes. Thank you very much for listening. Subscribe, respond, and give yourself a medal for what you've done in your practice relative to what we've discussed today. Thank you.